welcome to this April 29th, 2020.
Hold up. You're not broadcasting.
I'm not.
Nope.
Not yet.
It's afternoon and welcome to this April 29th, 2020 City Council work session. Thank you for joining us in this new remote meeting format we're using in response to Governor Brown's stay home, stay safe order. This format enables the City Council to meet and take care of business while keeping its members, staff, and the public safe. For work sessions like this one, where there is no opportunity for public comment, those wishing to access the meeting can do so by watching the live stream available on our website, the broadcast on Comcast Channel 21, or calling in to one of the phone numbers listed for this meeting on the public webcasts and meeting materials webpage. And as always, other avenues of communication with me and city councilors are available, including email and voicemail. Thank you again for joining us. And our first item of business is another update on COVID-19, and I will turn it over to the manager to introduce our speakers.
Thank you, Mayor. As you know, we've been trying to use our Wednesday meetings to just talk about the emergency operations response. And so I'm really grateful today that Karen Gaffney and Dr. Patrick Leckie have joined us from Lane County. And I want to just give like a major kudos to both of these leaders. I've worked with Karen for many, many years and Dr. Leckie too, and have been super impressed with how they have just kind of been on call for, I don't even know how many days. I think our EOC has been open for about 47, and I think they were open several weeks before that. So I think they're probably going on 70 straight days of working and doing a great job, as you can tell by the numbers in our county. And so I'm really grateful that you're joining us, Karen and Dr. Leckie. I'm not sure which of you is going to kick it off, but thanks for all that you're doing and keeping us safe.
Thank you very much, Sarah, for those kind words, and Mayor Venison, City Council. I really want to appreciate how what a great partner the City of Eugene has been with us throughout this process. Chief Heppel, as my counterpart as the incident commander at the City of Eugene, has been available around the clock as we've worked hard at the beginning of this incident to make sure that we were putting everything in place that we could to contain the spread of disease and really protect the people who live in our community. And I think when the nature of the emergency is a pandemic, it's even more important that we have regional strategies and a collaborative approach, because the virus doesn't really respect what our jurisdictional boundaries are. And in order to get to where we are now, which I think is feels like a relatively good place given our current number of cases and people who have recovered in our community, we are only able to do that because we pulled together as a community to do what we needed to do with the tools we had in our toolbox. So I'm not going to take a lot of time this morning teeing things up. I want to make sure that Dr. Leckie has an opportunity to share some of the information that's on his mind, and then of course to have enough time for questions from counselors. I would say that our primary focus has been, how do we flatten the curve? And I know you've talked about that in your regular updates as well. And we are continuing to hold at 50 positive test results in our community so far. I feel like as a community, we've done a really good job with physical distancing and managing that spread. And so that puts us in a place now where we can begin to consider what would it look like to slowly, safely reopen our community. We are at the beginning of a pandemic. The tool in our toolbox really is physical distancing. We don't have vaccines. We have still growing information about what the virus is. And so our main tool has been physical distancing. And now we're in a position where we have sufficient PPE in our community. Our healthcare providers are in a position to be able to respond quickly. And as soon as we get our testing where we need it to be, we'll be in that place where we can confidently begin to ease some of those restrictions, knowing that it's critically important for us to monitor the situation and for everyone in the community to understand that if we start to see significant increases in the spread of disease, then we will need to slow down until we can again get that under control. And there may even be some instances, depending on what outbreaks occur, where we would even need to go back to doing physical distancing. So this is far from over. While I'm pleased that we have been able to contain the disease in the way we have, I would expect that as we slowly open things up, we will see more cases. And at the county, we've been putting pieces in place to make sure we're able to respond. So I'm going to talk about just a couple of those, and then I'm going to kick it over to Pat, who has such an amazing depth of knowledge on all of these things that I know he really has the information that you'll want to hear. Nationally, we've been talking a lot about contact tracing, and that really has been the bread and butter of what public health does. And we have been doing contact tracing in this community since the beginning of this outbreak, and we do it on other communicable diseases as well. So what that means for people who may not have been hearing about this in the news is it means whenever we have someone who tests positive, we immediately interview them, find out who their close contacts are who are also at risk of getting disease. Then we immediately reach out to them. We have trained public health nurses who interview them, find out if they're symptomatic, help put pieces in place for them to be able to isolate and quarantine. If they become symptomatic, we get them tested, we find out who's in their circle, and do that until we're able to quarantine and isolate everyone so that the disease no longer spreads. So that's really the purpose of contact tracing. And as we do more testing in the community, we expect we will find more people who test positive. And I just want you to know that we have positioned the resources we need to be able to do that contact tracing for each of those people as well. So I think I'm going to stop there and actually not talk about testing at all and completely let Pat do that. Some of you may know in his past life, he was a state public health lab director. So he's absolutely the right guy to ask questions about testing and labs. So Pat, do you want to take it?
Sure. Thanks, Karen. And I was planning to pick it up there, and thanks for dropping the baton right there, because I think testing is a good place to start. Early in this pandemic, there was a clear shortage of testing in this country and locally. And we were fortunate 3 weeks ago that Peace Health was able to start testing at the Riverbend laboratory. They don't have an infinite pipeline of reagents and controls and such that they need. So it was a stuttered start, but now that pipeline is getting more full of the needed products, and they're testing. And then, of course, the relationship between the University of Oregon and Mackenzie allowed them to start testing in volume last week, Monday. And while we're not where we want to be on local testing, it's such a massive improvement from having 4 commercial private sector laboratories providing all of our testing, and 100% of that being done out of state, with the typical logistical problems of a long turnaround time before you get test results, sometimes stretching out to 10, 12, 14 days, which makes it really hard to know what's going on the ground. So we're very happy with that local testing capacity that we now have, and with their plans to increase that testing capacity. Now, that's the happy side of the coin. The sad side of the coin is we still don't have enough testing capacity. And if we were to have a massive second wave, which we hope we do not have, and we're going to try to prevent, we would really be stressed with local testing. So testing is a very difficult arena. This PCR testing is a very complex test, requires master's and PhD level people to do the work. You have to be what's called a CLIA, high complexity laboratory. It's not something you can turn on overnight at all. In fact, typically it would take at least a year to start up a lab from scratch. And what that means really is, of the 33 local health departments in Oregon, 0 have a laboratory. It's not going to be something that the local laboratories are going to do. You have to not only have the appropriate staff to do it, but you have to have demonstrated proficiency, which you do with what's called PTs, or proficiency tests, where they send you unknowns over the course of several months, and you demonstrate that you're getting the right answers. And that takes time before you have a clinical lab. So because of that, we are reliant upon the private sector and our state public health laboratory. And again, we're thankful that they are growing their capacity. I also wanted to talk a bit about some of the things we're hearing, and I suspect perhaps some of you are hearing them as well, with regards to this virus compared to, say, another respiratory virus such as influenza. And, this virus has only been present in humans as far as we know for 120 days or so. The first case in Wuhan, China was December 8th. Anyone who's worked in this space for a while knows that there are laboratories and clinics and hospitals that have frozen serum somewhere. And a year from now, somebody will thaw out a specimen and test it, and it'll be positive for COVID. And it might have been September of last year, so months earlier. So I don't suspect December 8th is the de facto first date in humans, because, again, it might change. But it's a good starting date for when the pandemic began. So in that, 4 months or so, of course, it's spread around the world. We know that, but we have learned a lot, but there's a lot we don't know. And until we know everything we would like to know, we're still in the data gathering stage. So antibody tests are coming on the market. We have no idea which particular antibody will result in long-term immunity, or if there even is long-term immunity. There are quite a few different what are called IgG tests coming on the market. Each one is a different IgG antibody. Some of them may show that you were infected, but just because you have that, you may have no immunity whatsoever. So it's not standardized. We really have no idea how to use the antibody tests. So we're really reliant upon these fancy molecular tests that actually do the diagnosis instead of the body response. So I'm going to stop there with testing, but comparing this to influenza then, we look at the data we've gathered in those 4 months time frame. And having been through some outbreaks like this over the years, the easy part really is the numerator, the people who are actually sick, and they go to a doctor, a nurse practitioner, a PA, they get a sample drawn, we get a test result. The harder part is the people in the denominator, and to really understand how big is this spread, how big is the population that's spreading to, and then further on, figuring out the asymptomatic people who actually got infected but never presented to a provider and actually had a test done. So we're in that stage. We just don't know. We think about 4/5 of people have asymptomatic or mildly symptomatic infection and will never go get tested. So we're figuring that into our equations of building immunity. We also have a less than good sense or less than great sense of the case fatality rate. Clearly, some people are dying of this disease. Some people may have died from it and they weren't tested for it because they had other reasons to pass away. We think that number is small in working with the county medical examiner, but it could be 1, 2, 5% of these deaths are being missed. So we're trying to figure out the data around that. And then when you compare what's happened in literally about 90 days in North America with 55,000 deaths or so to what a typical flu season is like, where you might have between 10 and 60, 70,000 deaths a year, that's over the course of 6 full months. This clearly has killed many more people than die in a couple months, 3 months with influenza each year. So the limited time we've had with it, this has not shown up at all like a typical seasonal influenza year. That's a lot of deaths in a very short period of time, and we just don't see that with the seasonal influenza. I also want to make a couple comments about isolation and quarantine. There are several 30-minute, 1-hour-long webcasts going viral, so to speak, and I watched one recently of a couple docs down in California. It's an hour long. I gave it an hour of my time, and these were emergency room docs saying that this is just like the flu and we should reopen everything. And I wrote up a commentary to it and sent it off to the person who sent it to me. And I said, they may be physicians, but they're not epidemiologists. They're not public health professionals. And they've confused some very key things in public health that, frankly, before I went into public health and I was seeing patients full time, I confused as well. There are differences between isolation and quarantine that are fundamentally different. There are differences between incidence of a disease and prevalence of a disease that are fundamentally important. And many of the items that you're seeing on the social media are confusing core public health issues. And I think it's really important to note that many aspects of this particular virus in the few short months that we have show that it's significantly more lethal than typical seasonal influenza. But there's a lot we don't know. And it's interesting to me on a professional level that the hardest hit areas are those really dense populations. New York, Milan is the second most populous city in Italy. Wuhan, China is 11 million people, a megalopolis. Seattle is not a small city. Parts of Louisiana are really getting pounded right now, over 20,000 cases. And their population is about the same size as Oregon, and we just passed 2,000 cases in Oregon. So, it's really, there's a lot we need to learn, and we're in the data gathering phase and in the responding based on that data gathering. And I think we really need to be cautious with interpreting things clearly in a clinical realm and not taking into consideration what the public health and the medical epidemiology realm has used for years and years and years. And, isolation and quarantine is one of those. And I'll just finish with this and go to the Q&A. Quarantine is for people who are healthy but exposed. Isolation is for people who are sick and you don't want them to spread it. And some of the questions I'm seeing on social media about have we ever quarantined people, as a public health professional, it makes me chuckle. The Center for Disease Control has about 20 quarantine stations throughout the country, most of them allied with major airports, the ABCDs of Atlanta, Boston, Chicago, Dallas, Detroit, etc. And we quarantine all the time in public health for communicable diseases. There's a list of quarantinable diseases. It was last updated by President George W. Bush, I believe, in 2003. And if you were really to test my mind, I have a feeling it was in April of 2003 during his first term. And this is something that we do quite frequently. And it's a little bit frustrating to public health people to think that we're doing things we've never done before. In actuality, we're doing things that have been tried and true for decades, if not centuries. So I'm going to stop there and open up to questions. Happy to take those with just the caveat that there probably are things that I won't be able to answer well, and maybe the same with Karen. We'll do our best.
Thank you so much. That was critical pieces of information told in a very discreet and concise form. So I very much appreciate that. And I don't see any hands raised. Do I have any counselors? I've got Alan. Okay, Alan and then Claire.
Yeah, Doc, the question I had is there's a lot of talk about Sweden and their test. John Hopkins just came out with a report analysis of that I saw on CNN website that compared the death rates per 100,000 in Sweden versus Denmark, Norway, Finland, and Sweden's was, when you do it per capita, kind of that deaths per 100,000, they were at 2194, Denmark at 400. So Sweden was 3 times Denmark, 6 times Norway, 6 times Finland, 10 times the Czech Republic. So it might be too early to tell, but that experiment about getting herd immunity, what's your thoughts about that?
Well, Karen and I have talked about this before, and I've talked about it with our communicable disease staff. In my mind right now, and this is my personal view, but I think many hold this, maybe using different words, there are a lot of different races going on behind the scenes. And one of those races is the race for herd immunity. One of the lucky things about this particular virus, as far as we know thus far, its reproduction number, or the R sub 0, is what we do in mathematical infectious diseases, is about 2.5 or so. And the herd immunity rate that you need mathematically is just 1 over the R naught. And 1 divided by 2.5 is 0.4. So you need 60% herd immunity to prevent massive wildfire outbreaks for an organism like this. So we need about 60% of people to either get immunity through a vaccine, which we don't yet have, but hopefully we'll get one next year sometime, or they get a natural infection and they build up enough antibodies to provide immunity. Now, that sounds like, 60% sounds pretty high, but an organism like measles requires close to 95% immunity before you can prevent wildfire type of outbreaks, which is why, we had the outbreak in the Portland metro area, why we had the Disneyland outbreak in 2015 that spread, dozens of people in just a couple days. So we're lucky that the immunity required is only around 60%. And so that's a good thing. The race is the 4/5 of infections that are either asymptomatic or mildly symptomatic. Those people are getting some immunity. If you were a betting person based upon other coronaviruses that circulate in the human species, you would say they're probably going to have immunity for a year, maybe even 2 years, and that'll give us some time to get a vaccine and to get antivirals that work. And I'm kind of hopeful looking at some of the data. I think we'll probably get a year and a half, maybe 2 years of immunity, which is a good thing. But there's a lot of other races going on. The race to a vaccine, the race to antivirals, the race to preparation, getting our pipeline filled for laboratory and PPE. So I think that the choice that the Scandinavian countries made, in particular Sweden, was looking at that race to getting herd immunity through natural infection, 4/5 or 80% of which would be mild or asymptomatic and would not overwhelm their hospital system. And if you look at their footprint on the ground, it's a small population-dense country. You know, they're close to 10 million, if I recall. You know, smaller than the metropolitan area of New York or LA. And pretty local population centers with a really good hospital complex. And they could monitor it pretty reasonably well. I would not have chosen that if I would have been their country epidemiologist or state epidemiologist. I think we just didn't know enough about this virus. But if it's going to work in any country, it would be a country something like that, or maybe Singapore, a really, really dense, nation state of 5 million people. But it doesn't seem to be working. This virus, unfortunately, 100% of us were susceptible when it first crept out of the animal population. It's going to be around infecting us for a few years before we get any kind of herd immunity that's overly helpful.
Thanks.
Okay, Claire.
Thank you, Mayor. Thank you, Karen and Dr. Ludke, for joining us today. It's very reassuring to have you both at the helm during this time, and I really appreciate all of your extraordinary efforts to help keep our community safe. I just had a couple of questions. You talked about testing and the challenges there, and having to rely on the private sector to work closely with us to ensure we have enough testing. So I just wondered if you could elaborate a little bit more on what your role will be in working to ensure that we can expand testing to the level the governor has indicated it needs to be in order for us to start to safely open up parts of our community.
Yeah, happy to do so. So I think there's several points in there where we are playing an active role. The first is with those two local entities, Mackenzie and Peace Health, work with them literally every day. Today we had an hour-long meeting looking at prioritizing and honing down on what it is we feel public health will need to have set aside. I was going to say if we get it, but I'm going to say when we get an outbreak in a long-term care facility or the jail or some other congregate setting. It's pretty amazing that we haven't had one. I think part of it is because we're doing really good contact tracing and we're working very closely with each of these entities to get them up to speed. But we have asked both of those hospitals to give us right now 50 tests per day that are set aside for public health use. And they're working with their C-suite to figure out how they're going to make that happen with the internal needs that they have to test their staff and to test patients who are being admitted to the facility to make sure that they don't so-called contaminate the facility with somebody who's incubating COVID. So that's number one, continue to work with the two local testing sources. Number two, you probably know for well over a month, we've had a 4 o'clock call with the provider community every day. And this last week, we went to Monday, Wednesday, Friday. And that call typically has 80, 90, 100 phone lines on. Some of the rooms have 10, 15 people in it. So literally 200 nurses, doctors a day from long-term care, acute care, hospitals, etc. And I run that meeting, and I'll be frank, it's pretty stressful when you have a bunch of docs peppering you with really hard questions. But it's a really important meeting for us to come together as a community and say, early on we were saying, hey, we have really shortage of testing. We don't have nearly enough. We have to focus these limited resources on this specific set of population. So people who are critically ill, they're in the hospital, they need to be tested. And if it's COVID, great. If it's not, if it's something else, we got to treat them appropriately. So we need tests for them, and then other high-risk groups, et cetera. So we continue to leverage that group. It's now Monday, Wednesday, Friday, and we work very closely with them on the molecular tests as well as the new antibody tests coming on board. And then number 3 is being really creative. So back in January, I don't know that I was the first one to reach out to the university, but in a former life, I was a university doc, and I worked with dozens of laboratories that have all sorts of capacity and in the molecular space. And I remembered that, and I called up the university and said, hey, you have fancy labs doing all kinds of cool stuff. Can't you redirect that to human testing to help us? And, the universe, I'm not convinced that nudged them to work with Mackenzie, but they're doing all sorts of things. So we're actively working with the university, not just on the Mackenzie project, but on several other projects and with their student health center as well. And then we're working with the other health officers. So we have a health officer caucus. There's 33 health departments in Oregon. And we're working with Benton County because they're working with OSU to get them to do genome sequencing testing. The university here at Oregon is also going to be doing some genome sequencing testing. So I think that third bucket is get creative. How can we nudge others? And the latest one we're doing with local clinics is there is a fairly simple and rapid test that's pretty good. Well, there's actually several of them now, but there's at least 3 that are pretty good that could be done in a doctor's office, a small one, like a doc in a box, as we sometimes say with the jargon. And we're trying to encourage, as their supplies come up, trying to encourage some of the practices to consider bringing that on board. And they could do some of their own testing locally as the production of the necessary reagents grows. And we're getting to the point now that I think there's going to be a pipeline come the fall where there will be enough opportunity for those practices who want to bring on some of their own local testing in their own clinic, and there'll be enough supplies for them to do so. So those are kind of the 3 main areas. Sorry, that's a long answer.
No, that was great. Thank you. Don't ever feel like you're giving us too much information. I work with the hospitalists over at Riverbend and UD, and they are a bunch of big brains. So I can appreciate what you said about being peppered with questions by them. And my second question is more of a request. I wondered if you would be comfortable sharing that response you mentioned that you had to the video of the ED docs or some variation of it. I'm sure it's fairly technical, but I still feel like it might be helpful to us as elected leaders if we're getting engaged in those kinds of conversations with folks who are saying, well, I saw these 2 doctors on, YouTube, and they said this isn't any big deal. I just kind of feel it might provide us with some content and context to be able to respond in an educated way. So I don't know if you'd be willing to do that, but that's my other request.
So maybe what I'll do, I'm not against it. I think that I tend to be pretty inclusive and ecumenical. That seems to me the way in public health that you get the most done is building a coalition rather than creating enemies. And maybe I'll review it with my staff. I'll tell you a few things here. I don't know if you happen to have seen that particular video. It was just picked up by Fox News yesterday, and those 2 gentlemen were on Fox. I was very surprised. Well, actually, I wasn't, because it already had over 1 million views. So now they got called up by major media. But one of their talking points, and reporters love these little jargon phrases. One of the docs reaches his arms out as far as you can reach it and says, millions of cases. Then he pulls his arms together, his hands right next to each other, small amount of death. Millions of cases, small amount of death. And my first reply, as I sent it off to the gentleman who's a pharmacist who sent this to me, I said, we haven't even passed 1 million cases in the United States, and we already have over 50,000 deaths. That soundbite, millions of cases, small amount of deaths, is just factually incorrect. So those little things, and that particular docs did that arm spread, millions of cases, bring it together, small amount of death, half dozen times in his 1 hour. And, reporters love those sound bites. And then they talked about all the initial models were completely incorrect. And, my response was, I don't know what models they reviewed. Being a scientist, you just can't assume. You have to say, well, what models were you looking at? But several of the models that we looked at have been surprisingly, almost eerily accurate. And it's and then the secondary issue is, hey, some of the models were based upon doing nothing. If you don't close business, if you don't drive social distancing, if you don't look at these other initiatives, this is what might happen. And maybe that interpretation was failed, and it was an opportunity to do better education. So maybe Karen and I will look at my response and decide what we want to do.
That'd be great. Thank you, Dr. Ludke.
Thank you so much, Dr. Ludke. I think that would be very helpful because we are all, as Claire has noted, we're all hearing from constituents and being able to share that kind of response be, I think, very helpful for all of us. And I want to respect our time and our schedule. And thank you both, Dr. Ludke and Karen, for joining us and sharing your expertise and for the really superb work you're doing to keep us all safe and on the right track. So thank you very, very much for joining us. And reminder that council, you can always turn to them again. They can come back for future updates. They're a resource for us. So thank you.
Thank you.
We appreciate that.
Sure appreciate your collaboration.
Thank you. And so our next item of business is to provide an opportunity for applicant for both the Budget Committee and the Planning Commission who was not able to participate in the interviews before. Jessica, I'm just checking, is Rebecca on the line and available to make her statement?
No, she is not with us.
Okay, so we will then move on to our next work session agenda item, and possibly if there's time at the end and Rebecca is able to call in, we may be able to circle back, but I'll leave that to you, Jessica, to keep me. You can text me and let me know what the status is. Okay, so we are ready for state update on the governor's framework, and we have a guest. Sarah, do you want to introduce our guest?
Sure, I'll just, because I want to share the same amount of gratitude. Sarah Means has been doing a great job since she went to Regional Solutions, has been so communicative with us on so many things. And as you know, she's been sending us a daily email. So really working hard, and met earlier this week with the exec team to give this presentation. I know there's new information now. So thank you, Sarah, for being willing to join at such short notice and help us out here.
Thank you, Sarah, and Mayor Venus and councilors. It's great to see you on a computer screen. I hope you're all well and staying sane in this challenging time. I'm going to share my screen because I do have a slide deck that is generally pretty helpful to use and follow along with me. So hope that's okay. Just give me a moment here. Okay, so I'm going to try and go through this relatively quickly. As Sarah mentioned, there is a little bit of new information. It's incredibly dense, the new information coming in related to specific sectors. So we'll touch on that just briefly, and then I'll be happy to answer any questions moving forward. I'm really happy that both Karen and Dr. Ludke were on the call before I gave my presentation. Clearly take your public health recommendations from them, not me. They are your subject matter experts and doing a fantastic job for you and all of Lane County. And so there are likely to be some additional public health questions as we go through this, and more likely than not, I'm going to say, I don't know, but let me find out. So appreciate your grace and patience with me on that, because that is certainly not my subject matter expertise. But we are going to be talking about testing and contact tracing and those sorts of things as part of this framework. And so happy that they were able to maybe help keep things clear prior to entering this conversation. So with that, the federal framework, you all have likely seen that coming down from the president. What I will say is that the federal framework and the state framework are generally aligned. There are a few differences, and we'll make sure to point those out through this slide deck. But overall, I think the takeaway there is that the federal government and the states are definitely working from a very similar playbook as it relates to reopening framework. Just, a couple of slides here to I think that are important statements to make. We don't make the timeline, the virus makes the timeline in this situation. And Dr. Fauci is very clear about that. And I think it's an important reminder as we move forward. And really, Dr. Lutke has alluded to this in his earlier comments, but we will be living with this virus until there is immunity. And that's going to be a little ways off. And so what can we, I think that the challenge and the question really is, what can we do as we wait for vaccines and testing capacity and on all of those things that really need to occur in the next number of months? What can we do to now make sure we're keeping our economy moving, but also making sure that we are safe moving forward? I heard flatten the curve a little bit ago. I think Dr. Lutke said it, or Karen, one of them said it, and that's exactly what we've been trying to do. And this particular visual representation shows us this, and it's based on some modeling that has been occurring. Basically, what we're showing here is that the blue line is representative of where we are and where we are projected to go if we continue aggressive interventions. That orange line is indicative of what the modeling says will happen if we return to a more moderate intervention. So bottom line is, if we reduce social distancing too quickly, we will see a spike in cases. So as I mentioned, President Trump released his Opening Up America Again guidelines on April 16th. That feels like light years ago for me. I don't know about you, but it was actually only about a week and a half ago. And the following day, the governor released these guidelines. So we've been talking about these for a little over a week now. I will say that the governor does have her medical advisory panel and working with the Oregon Health Authority to really thoroughly vet and review this framework. And like I mentioned before, I think at a high level, we're very much aligned, but there are a few differences. And we're seeking that additional guidance from the medical advisory panel and Oregon Health Authority on those differences. The framework is set up with these three specific areas, and we'll go into a little bit more detail on those in the following slides. But I think, what's most important to take away here is that there's gating criteria, and there's three specific components within the gating criteria: symptoms, cases, and hospital capacity. There's core state preparedness, three components there as well: testing and contact tracing, healthcare system capacity, and including PPE and surge capacity, and then a variety of different plans that we're going to need to have in place as it relates to health and safety. And then all of that to say, we're really looking at a phased lifting of restrictions once we can address points 1 and 2 on this slide. So let's start with the gating criteria, point 1 on the previous slide. Again, Oregon is likely to use some modified metrics. We're defining those now. In fact, I think the medical advisory panel has reviewed the metrics, and we should be seeing something soon. I think the other piece of this, though, is that we're a very large and diverse state, certainly geographically speaking, and the governor recognizes that, and what's right in one region might not be right in another region. And so we're taking that into consideration moving forward. So with regard to the criteria itself and symptoms, you see there downward trajectory in both influenza-like symptoms reported within a 14-day period of time, as well as the COVID-like symptoms within that same 14-day period. So downward trajectory of both of those things to meet that criteria. With regard to cases, again, downward trajectory within a 14-day period of time of documented cases, or there's some flexibility here to adjust for a percentage of total cases depending on what makes sense in a particular situation. And then hospitals, they need to be able to treat all patients without crisis care and have robust testing program in place for at-risk healthcare workers, and including some the antibody testing that Dr. Lutke mentioned before. With regard to core state preparedness, testing and contact tracing, I mean, this is really just going to be a conversation that we're going to be in for, quite some time in terms of making sure we have adequate supply capacity and ability to test individuals. I want to draw your attention to the Sentinel surveillance sites. This is, I think, an important point. These sites are really screening for asymptomatic cases. They're set up with good laboratory facilities, experienced, well-qualified staff. They are able to identify and notify on cases. And really what we're talking about here is transitioning from a passive tracking system to an active tracking system. OHA, Oregon Health Authority, is working with county health departments and hospitals to create a plan. They were working on that last week and this week, and they're expected to present that to the medical advisory panel. And we're expecting the medical advisory panel to review that in the very near term. I think this is an important point because this is really when we will have a better idea of how close specific counties are to moving into phase one, how well prepared they are in terms of testing and contact tracing. So important points here to note as we move forward. And then healthcare system capacity. I'm sure you've all heard us talk a lot about PPE, personal protective equipment. That's going to be critical moving forward in terms of both existing supply, and then supply chain reliability, and then ability to surge ICU capacity if needed. Then I mentioned plans. These are just a few. There's likely to be more that are needed. I'm certain of it, but so we just need a number of specific plans as it relates to health and safety for state, counties, industries. It's really important because we have to closely monitor metrics moving forward. If a certain, Karen talked about this, if a metric is triggered, we need to know, what that means. Do we need to start to implement the physical distancing standards again, or maybe it's a positive metric and we can start to think about moving into a next phase of this. But in either regard, we've got to understand the metrics. We've got to understand the plans that are, and then have plans in place so that we can adequately respond and be prepared. So if you've now seen the gating criteria, you've seen the core state preparedness. Now, I think the important thing to keep in mind is that we've got to go through each one of those in order to be ready to enter phase one. We are not in phase one. So phase one begins at the governor's direction after all of that information and prep work, and the metrics are where they need to be. In phase one, we have guidelines for individuals and employers. None of this is going to be surprising to any of you. Good hygiene, face covering, stay home if you're sick. Employers are going to need to have appropriate policies in place to make sure that they're keeping their workforce and their customers safe and healthy to the best extent possible. We're also going to make sure vulnerable individuals need to continue to shelter in place in phase one. When in public, those physical distancing standards need to be recognized to the maximum extent possible. Excuse me. Avoid socializing in groups of 10 or more people. So that's sort of speaking to, a lot of folks are very curious about mass gatherings, and that question comes up a lot. We're saying 10 or fewer people in phase one. That does need to be reviewed by the Oregon Health Authority and the medical advisory panel in conjunction with local public health, but that is the proposal out there currently. And common areas need to remain closed where people congregate and interact. Minimize non-essential travel and continue to telework whenever possible. This slide is really where I want to point out a few differences between the federal proposal and what's under consideration for the state, and where we've seen some additional information just even within the last 12 or so hours, frankly. The first column there is the activity or the business industry in question. The middle column is the phase 1 federal proposal, and the final column there is the what's under consideration for phase 1 here in Oregon. Schools are likely, schools will remain closed under the federal proposal, and that is true under the Oregon proposal as well. What I will say and add is that childcare is something that we really need to be thoughtful about. I'm not saying anything that you all don't know. We were struggling and frankly in a bit of a childcare crisis entering this pandemic, and we've not done anything over the last 2 months to help that. So we are meeting and well, they have met. We have a proposal for how to open childcare in phase 1 so that our parents have a safe place as they're going back into the workforce, have a safe and healthy place for their children to go. So I don't want to dig into that too much in that specific proposal here, because like I said, we'd need another couple of hours to get through it. But happy to make sure that those are available to you. They're out and about already, and I can get the information to Sarah and others. Actually, a number of people on your staff already have it. So we can make sure to get that information available or to you all. Visits to hospitals and senior living facilities will remain prohibited under both proposals. Large venues, so sports, theaters, churches, places of worship, likely to remain closed during phase 1. I will say that we are having some conversations about churches and places of worship. I'm not sure exactly where that's going to go, but there have been some additional conversations about that particular piece of this. So stay tuned. I might have some more information later in the week. Sit down dining and bars, let's maybe take those two one and the same, because with the Oregon proposal, we've had business owners really participate in a very operationally focused conversation with the Oregon Health Authority to create a phase 1 plan for reopening. Again, that's along with childcare that was released late last night. And so we have some additional information on guidelines. I will say these are very operationally focused and really meant to give specific guidance to these business owners on how they could reopen their establishment within the phase 1 and still maintain these very strict physical distancing and sanitation protocols. So some good information there, hopefully, for business owners to be able to dig into and really have some clarity around. Gyms will remain closed in phase 1. The governor has said that on multiple calls that I've been on. As you know, as hard as that is, certainly it's just in her mind that's the right decision to make for phase 1. So I don't believe that will change at this point. Non-emergency procedures. We actually, you may have seen the press release come out last Thursday, I believe it was, that is issuing or allowing for non-emergency procedures to reopen as of Friday. So that's happening. That was really, really important for a lot of our rural hospitals who rely on this type of work in their day-to-day. And so they were able to come up with a plan and some policies to make sure that that is appropriate to do, and everybody was comfortable enough to move forward as of May 1st. And then personal services, those are the businesses like hair and nail salons, tattoo parlors, those sorts of massage services. They're very challenging. You can't at all really meet the social and physical distancing standards and protocols. So we have a work group working on that right now. That information has not yet been released, the guidance on how they might reopen in phase 1. So hopefully we'll get some more information on that later this week. This is just to say, we're a big state. I said this before, we're a big state. There's a number of counties, I think 5 at this point. I believe that's still the right number, that have not seen any cases in the state of Oregon, generally on the eastern side of the state. And I know that they're very anxious to enter into phase 1. They've been communicating with our office on plans for how to do that. We'll see what happens. I think that this is really just to say the governor is certainly committed to looking at a regional or county by county approach. And to that end, we've thrown out this proposal. I think most of this will likely stick for the most part, although there is some additional work being done on it for a county by county reopening, and really what we would need in order to make that happen. So you'll see that here on the screen, a formal request to the governor, including a variety of things, particularly these 3 bullet points, talking about PPE reporting and supply chain reliability, hospital bed surge capacity from the hospitals within the county, recommendation letter from the county public health officer, and a vote of the county governing board certifying PPE for first responders is sufficient. So there's a lot in there, and more detailed guidance to come as we've been getting this feedback from counties and public health officials on what, and hospitals on what this might look like. So again, there are phases 2 and 3. We've not spent a lot of time on that at this point because we've been so focused on what the gating criteria means, what core state preparedness means, and then phase 1. But this is really just a nod to say, when we do get to phase 1, this is going to be a very iterative process, as you might imagine, waiting 14 days, passing the gating criteria again before we can move on to a next phase. And so iterative process, relatively slow rollout. There are a few bullet points here as it relates to phase 2 and 3. Again, we've not dug into those very deeply, but as you might imagine, it's a lessening of restrictions as you move further through the phasing. Again, we've been out giving this presentation a lot. We want to make sure that everybody is informed and has the ability to provide some level of feedback. And so that's why I'm here today, excited to give you the presentation and make sure you have this information in your hands so we can make sure everybody is informed. These are the sector conversations. I referenced childcare, restaurants, personal services. I'll also say retail came out last night as well. So we have sector-specific plans in restaurants, retail, and childcare. We're working on personal services, transit, and outdoor recreation as we speak, and hopeful for additional information on that later this week. And then this is just a timeline. Week of May 4th is really the next significant date where we expect to have some finalized completing the details of these this framework and the geographic criteria and really the step-by-step reopening Oregon plan. And I think you all have likely heard we have ongoing coordination with West Coast states. That includes California, Washington, and I believe it was on Monday we announced Colorado and Nevada as well. It's important so that we are communicating at a high level and not having any unintended consequences on one another as best as possible. We definitely had some challenges in the shutdown period where particularly our border communities had some struggles, and we want to do our best to avoid that and be good neighbors. And then this is a few resources that we've been using as we've been putting together the framework in our office. So if you're interested, you have that information. So I'm going to stop there. And I know this is a very dense document and takes some time to process, but I want to stop there and just go ahead and answer any questions if there are any, to the best of my ability.
Yeah. Hey, Sarah, before you completely stop, will you share the definition of vulnerable populations? Yeah. Thanks.
Yeah. Let me I'll just scroll and read it to you. The vulnerable individuals definition is elderly individuals or individuals with serious underlying health conditions, including high blood pressure, chronic lung disease, diabetes, obesity, asthma, and those whose immune system is compromised, such as by chemotherapy or for cancer or other conditions requiring such therapies. So that's the formal definition. I will say the age, I got the question of what is elderly. 65 and older, I believe, is the CDC guideline on that. So, so there you have it.
Okay, thank you very much, Sarah. That was an excellent rundown. It's very helpful. I know our community's I'm very interested and eager to see those sector plans and rollout. So I'm glad that's coming soon. I have Claire in the queue. So Claire, I'll turn it over to you for question.
Thank you, Mayor. Thank you so much, Sarah. That was a very thorough presentation. Really appreciate it. I had several questions. On slide 7, I think it was, there was a reference to at-risk healthcare workers.
Yeah.
And I was wondering what was meant by the at-risk.
That's a great question. I actually haven't received that question yet, so I haven't tracked that down to get a solid definition. So, and I don't want to misspeak. So I can track that down and make sure we get a good solid definition for you and maybe filter that back through Sarah and others at the city.
That would be great. Thank you.
You bet.
I was curious on, because I think they are very important, the parameter about setting up sentinel surveillance sites. And I was wondering how the governor and her team was determining where those sites will be needed and who out in the broader community she will be engaging with to make that determination.
So my assumption is, Oregon Health Authority is going to be working with our public health officers and officials in throughout the state to establish and our tribal partners to establish where those sites are. I have not heard any definitive answer to that question at this point. My assumption is that they're still working through that. I do know that she's very much taking her lead from those who are in the public health realm to make sure that they really do have some of the best information and are better prepared to work on this than others. And so I know she's very much taking her lead from them.
Okay. And then there was the provision around a formal request that counties can make and what they had to do to make that. So how does that interplay with the governor initiating a phase? Is it something that is imagined to happen before phase 1, or do we have to be in phase 1? What's the interplay?
Yeah, no, I think this has been the challenge, one of the more challenging aspects of this, recognizing that, a regional approach might be the best way to go, but that complicates it significantly. And so, but just because it's hard doesn't mean we shouldn't be doing it. We just need to be very thoughtful about it. So if you think about, the gating criteria and the core state preparedness from a statewide perspective, you would just basically apply that to, let's say, a county specifically. So let's say we applied that to Lane County. Lane County would have to still meet all of those criteria and frankly be ready to enter into phase 1. And so that the request to the governor would be inclusive of all of that gating criteria and everything within the request that needs to be made, and they would be requesting to enter phase 1.
Great, thanks. And then one more question and then just a quick comment. So the personal services, the barbers, hairstylists, massage therapists, they weren't listed in the towards the end of the different slides, but I'm assuming kind of from how you referenced them earlier that might not be opening until phase 3, or is it?
No,
No.
so we're working on a phase 1 plan for them. As you might imagine, it's challenging because those physical distancing standards, just you simply, if you're going to cut somebody's hair, you can't be 6 feet from them, to the best of my knowledge.
Yeah.
So I think those are just a little bit more complicated and require a little bit more conversation. We had expected to see those yesterday with the others that rolled out, and they're just not quite ready to roll out those guidelines yet. So a few more conversations, but we are still working toward a phase 1 plan. I think it's important to keep in mind, just because we're issuing those guidelines, it doesn't. I want to be very clear about this. We've issued the guidelines for retail, restaurants, and childcare for phase 1. That does not mean we are in phase 1. And so they are not yet ready to reopen. We are issuing those to provide plenty of notice to those businesses so that they can begin to get prepared based on the operational needs they're going to have to pivot toward or adjust. But I just want to be really clear about that. We're issuing the guidelines in preparation to enter phase 1 at a later date.
So we got, the city council received an email that was also sent to the governor from a local massage therapist who was very concerned that her industry would be reopened in phase 1 and then would either have to choose to try to figure out how to do that, possibly at risk to her own health, and forego the current unemployment benefit that's now being offered to self-employed Oregonians. So she was just feeling like her industry is going to be put in this bind. So I hope that the governor is considering the interplay between, we might be opening up certain parts of the economy. That doesn't mean everyone who works in those industries is going to feel like it's safe for them to go back into that practice.
Yeah, absolutely. Thanks for bringing that up. I think that's an important point to make, and I know she's very much aware of that dynamic, and really why she asked to have these sector-specific conversations. And so, who's the folks in the room on these conversations are, the folks on the ground, the business owners, the folks that are really truly being impacted by these guidelines. Of course, there is the public health, these are guidelines coming out from public health and the public health perspective, because, the bottom line for all of this is that we've got to be healthy and safe in these guidelines. But yes, that dynamic we're very much aware of that. So appreciate you bringing that up.
Great. And then just a last quick comment. I'm very supportive of the coordination with other states around how we look at this. I think that's really smart and appreciate that the governor has decided to do that.
Thank you.
Thank you.
Okay, any other counselors with a question or a comment? See any other hands up? Hey, I have one follow-up comment on the specific sectors. I have weekly phone calls with a couple of different groups of our downtown businesses.
Yeah.
Sarah, we talked about it. Melissa joined us last week, and so they are mostly in one group is mostly restaurants and breweries. The other group that Melissa joined us they're mostly retail operations downtown. If they're interested in kind of weighing in, is that opportunity still open to them when we have our weekly conversation, if there's a way that they want to sort of review and weigh in, what's the process there?
Sure. Yes, absolutely. If I need to jump on a call, I think they meet tomorrow. Is that true?
Well, we are scheduled for Thursday, but we're adjusting that schedule. So I'll have to check in with you when we're offline. Okay. When that might.
Let me know. I'm happy to jump on. I apologize I couldn't make it last week. So yes, but I do need the feedback by Thursday close of business. So tomorrow close of business.
Okay.
because we're funneling that feedback up through the governor's coronavirus economic advisory council on Friday. So we want to be able to package that Thursday night to get that to the council on Friday.
Okay.
But yes, absolutely. And you and I can just connect offline directly.
Yeah, perfect. Thank you so much. And thank you. It looks like Alan Zelenka have a comment.
Yeah, thanks for that presentation, Sarah. You guys are getting around. That's the third time I've heard it. So
Yeah.
getting it out.
We're doing our job. We're doing our job then.
You are. Good work. I guess it's a local question. Maybe you can answer, Sarah. So to get to phase 1, you have to have 14 days of declining cases and symptomatic cases. Have we got to day 1 of those 14 yet?
Not to my knowledge.
Okay. Other counties may have because they don't even have.
Yes, on a county, if you're looking at it from a county by county basis, other counties likely have, yes. I don't, I'd want to defer that to Karen or Dr. Ludke as it relates specifically to Lane County.
Yeah, I think they dropped off, but Sarah, other Sarah? This is like the Sarah show.
And we had this conversation, and we're both SM too, right? So you can't even, yeah.
She's more awesome though.
No.
Did you
Sarah
want me to?
McCarry.
Yeah. Can you repeat the part you want me to answer to that?
Oh, so you need 14 days of declining symptoms and cases, and have we got to day 1 yet?
Chris is on the line. I think we've been at 50 for a couple of days. So we haven't had a case in the last 2 days. And I think the week before that we had 2, but Chris will be able to jump on that a little better.
Yeah, I don't, great question, Counselor. And I don't know that we have had the day 1 or picked the day 1 part. And so now I'm just going to speak a little bit more philosophically about that. We could have already passed day 1 also. And they're just simply not going to announce it because we're looking retrospectively at that data, right? And so we could come up and be like, oh yeah, we're 8 days into what we were meeting for our dating criteria. We're looking good. And then this weekend, it kind of maybe unraveled because some folks thought we were in phase 1 and went to the coast and it go from there. So, to say, yep, today's day 1, I don't know that they necessarily, and I don't want to speak as for Dr. Leckie on this, but I don't know if they look at it, say, yep, this is it, as much as we look backwards at the trend and the data per se. That's my thought.
Keep it surprised, please. Thanks.
Yeah, I think that's also what Karen said, was that we hadn't entered into day 1 yet.
Okay, thank you. Any other final questions or comments? Sarah, I really just want to thank you again for joining us and for the work that you're doing to keep us really up to date. I want to extend my appreciation to the governor because I think she's really been excellent at reaching out to the communities and hearing our concerns and responding to them. So thank you. I think the process has been really, really excellent at keeping a two-way conversation going. So thank you very much for creating that bridge for us all to walk across. We appreciate it. And I think with that, I just will check back with Jessica and see if we'll close this agenda item. Thank you. And
thank you, everybody.
If our candidate, Jessica, has our candidate called in by any chance? We have a little time to listen from her.
No, we do not have the candidate on the line.
Okay. All right. Well, that is too bad. And we might just check in and we can follow up and see if there is a way in which we can connect with her before council has to make those decisions. But I believe that is the end of business. And that, unless anyone has something they want to bring up, we are, Claire.
I just wanted to repeat my potential suggestion for it's Rebecca, right? Jessica, to see if she might record a 3-minute statement about why she wants to serve on those 2 committees, maybe 2 3-minute statements, and get that to us. That might, since it's been challenging for her schedule to join us.
Yes, thank you, Counselor. We will pursue that option next.
That's great. Okay, thank you. Thank you all. Good to see you all. And we are adjourned. Bye.